Hello, I'm Lisa Loomis with Mad River Valley TV, and with me today is State Representative Adam Greshin from Warren. He represents the Mad River Valley towns in the Vermont State Legislature. We're here to talk about happenings at the State House, current events, and anything else that comes up today. Thanks for coming, Adam.
Thanks for having me, Lisa.
How's the job so far?
It's been enjoyable. You know, the first part, I would say, is the easy part, because you're listening, you're taking testimony, you're essentially educating yourself on all the issues. The hard part comes when you have to make decisions.
Sure.
So the easy part, and we have made a number of decisions. Most notably, I think a lot of work was done in the House Judiciary and Senate Judiciary Committee for the sex offender bill.
Mm-hmm.
So there's a big push to get that on the governor's desk before the break, which is at the end of this week. But many other issues are just in the formative stages, notably the budget issues.
Budget issues. Let's talk about the budget issues. Are you in agreement with the governor's proposal to cut spending in the areas it's been spent, or it's been proposed?
You know, I think the fast answer is no, because there are many areas that require more review. To the governor's credit, he put something on the table. And I think it was important for him to do that. I think it was important for the state to be able to take a look at what he believes we can save in the way of spending. But I think many of the areas that he fingered for cuts, I think, will be revised, and I think we need to look a bit more carefully. You know, I sit on the healthcare committee, so we are charged with figuring out how to make the programs either more sustainable or cheaper or both. That's going to be, it's going to be very, very challenging, very challenging. You know, the nature of many of the programs that we have, notably Medicaid, and a number of programs that will funnel through the Health and Human Services Committee, are programs that were instituted to help people who need help. And as you'd imagine, in the economy that we have, more people need help, not fewer. And so to think that programs that were put in place to provide assistance when people need it should be cut back in the times when they need assistance, that's going to require quite a bit of thought, and those decisions will not be easy. And I don't want to say that healthcare alone is
well, let's
the focus
just stick
of the
with
budget.
Medicaid just for a minute. The new administration has a fabulous media distribution system, and I get emails in my inbox every day talking about the federal stimulus and what it means state by state, and I've gotten breakdowns. $45 million for Medicaid for Vermont alone is coming our way. That was in my email last week. Surely that will provide us with enough funds that we don't need to cut Medicaid, right? I mean, if the money's coming in, we don't have our budget shortfall.
That will provide fund, and has provided funding for this year. So nothing will change this year. We won't need to make any difficult decisions this year. I think we will be able to fully fund the programs that we had intended to fund when the budget was put in place last year. But keep in mind, this year ends at the end of June. The state fiscal year 2010 begins July. So the decisions regarding Medicaid and any other budgetary item in the general fund have to be made over the next 3, 4, 5 weeks. So true, the stimulus from Washington will help us carry through to this year. We are now taking testimony and considering options for the next fiscal year. And you know, with Medicaid, and keep in mind, we spend all told, and by we I mean the federal government and the state government, we spend over $1 billion in Medicaid. It's fully a quarter of the money that we spend in all of state government.
Our gross domestic,
in all of state government. If you look at the general fund, which is about $1.2 billion, the ed fund, which is called another $1.2 billion, transportation and various other programs, we spend over $4 billion in this state. Now, also keep in mind, of the over about $1.2 billion we spend in Medicaid, 60% of that comes from Washington. So the state contribution is quite a bit below $1.2 billion, but it's still, you know, quite significant. And the amount of money that would be required on an annual basis to fund Medicaid fully, as we have it operating now, would have to grow year after year because these programs are growing in terms of their cost. So we need to take a look at these programs. And I can tell you, Lisa, that will be extremely challenging to do because when we look at the programs, we welcome people into the healthcare committee. And by the way, anyone is welcome to come in there. You don't have to be invited. You have to be invited to testify, but you don't have to be invited to listen. And there are many people who sit around the committee table. The room is almost always full. And the people who testify are either beneficiaries of or proponents of programs that help people achieve full medical insurance or medical attention or various other programs that basically deal with their health. And if you're not healthy, you're not functioning well. And if, for example, a child does not receive medical attention early on, as every child should, he or she, that could affect the rest of their lives. So
grows up to cost the school system more.
Absolutely.
If they get an ear infection and don't get any antibiotics, right? And they can't hear.
Which really gets to the heart of the problem. Most attention and most spending in medical care is on chronic care disease. And the way to prevent chronic health issues is early prevention and developing good habits early on. Many of the programs that are operated either by the state through Catamount or Medicaid are programs that incent people to get in early and often. And they are expensive. There is no question they are expensive. But the thought is if you get them early, you reduce your costs long term. And therein, in my view anyway, lies the biggest challenge to what we're trying to achieve. And I can give you a good example. I wrote a couple of weeks ago about colorectal screening, which in a nutshell is providing low-cost colon cancer screening for all who want it, all people who come into the office. And that is a classic example of early prevention. Most people, 90% of the cases of colon cancer occur in people who are over 50 years old. And so the thought is that if you screen people who are over 50 on a regular basis, and even people who are under 50, but particularly who are over 50, you can prevent or you can detect early signs of colon cancer, which you can deal with early on. If you deal with them later, the cost grows significantly and the disruption to their lives grows significantly. But there's a cost involved with early screening. If you charge people $25 for those people who have private insurance, which is what the mandate provides for, that $25 doesn't cover the cost of that screening. So that has to be shifted to someone who will pay that cost. So you're driving up costs for people predominantly on private insurance.
How do you balance the back end of that? No pun intended. Where
Good.
might have to cut that part out. Sorry. How do you balance the back end of that with costs saved from early detection, right? If you detect colon cancer at its inception, you've saved potentially
Hundreds of thousands of dollars.
500 times the cost of that $225, the difference between the $25 and the true cost of the screening.
Really what we're doing is we're trying to suck it up in the short term to provide for savings in the long term. Now, and this is true with far more than colorectal screening. It's true with many. For example, I'll give you another example. Dental coverage is an interesting, call it a similarity. For people, children predominantly, who have regular visits with the dentist early on, they can avoid many problems down the road. And there's now decent medical research which shows that oral problems, oral disease, can lead to many other diseases.
Right.
So if you get them early, then you save yourself money and you save a lot of grief for the people who are potentially affected by various oral diseases. but that too requires upfront costs. So for many of these issues with healthcare, we're making reasonable assumptions about early detection and early prevention. And we believe that we will save money down the road. Can we prove it?
Right, you're getting
Not
gradually
really.
getting healthier and healthier generations of people.
You can't, but you can't really prove it. You think, and there's a whole body of scientific evidence that tells you that you're doing better. But can you look at another country, for example, a European country or an Asian country that has universal health care and all the right processes in place? It's difficult to look at them and say they have, for example, lower cases of colon cancer or better oral health and thus better health long term. It's not, the data does not support that definitively, but scientific evidence and scientific research does support it.
So countries
And
that
so
have
we
had
know-
socialized healthcare or nationalized healthcare for 20 and 30 years, there's no indication of healthier populations? That's interesting.
I don't want to say there's no. What I do want to say is I can't point to any one study that tells me
okay.
that helps. But
Huh.
we're making reasonable assumptions, which brings us full circle, back to the original question. We are looking at programs and we are looking at reducing spending, considering reducing spending in programs that we know are good things to do. And those decisions are never easy because they affect people who need the help and because they violate good long-term assumptions about preventative care. But the money has to be there, and the what I would call the elephant in the room is, why can't the money be put there? In other words, we are operating under the tax policies and the spending policies that we have today. Can those be changed? We're looking very carefully at spending policies, but there are many people who have said we need to look very carefully at revenue policies too. And that, I think, will also receive a full vetting.
So let me back up to something you said before that. You mentioned that of all the money spent in the state, 25% of it is spent on our various healthcare programs. That's subsidizing.
I believe I said Medicaid. I think 25% is Medicaid.
25% is Medicaid.
I don't have the exact
So that's
numbers,
not,
but it's
is
very
that
high.
Catamount and Dr. Dinosaur?
There are parts, Dr. Dinosaur, for example, is a Medicaid program.
It is, okay,
through
good.
Medicaid. Catamount is not strict. Parts of Catamount are, but say an adult who would purchase a Catamount, the Catamount plan, that would not be through Medicaid. VHAB, Dr. Dinosaur, and so on.
Well, how about, so that's state money spent on healthcare. What if you add in how much money is spent in the private sector on healthcare?
Right.
Surely we got enough money to go into the pot somehow to create, or do we not have enough money if you combine public and private funding? The amount of money the state is spending, the amount of money the private sector is already
Right.
spending. Is there not enough money to create a comprehensive insurance program for us?
If you combined it all, I think the short answer is currently no. The private sector is spending, and by private sector, companies
Mhm.
or people
Your company, my company,
like you
right.
or I who might purchase a private health insurance plan. We are essentially already subsidizing the state programs, and we are subsidizing the so-called cost shift. For example, when you go in for a colorectal screening and you're charged $25, the insurance company is not really eating that. What they are doing is they are adjusting the premiums for private sector purchases higher to account for the fact that they're expecting to lose money on colorectal screenings at $25. So, the private sector is already funding a fair amount of the health care that is happening, and also through tax dollars. The general fund is predominantly populated by income tax, and the general fund is writing a check to to health care. It is taking a portion of the general fund and is funding health care.
Mm-hmm.
And that general fund is populated by income taxes. So, the private sector, either through their premiums or through tax payments, is funding health care for the state, as well as the federal government. Keep in mind, the federal government is paying, for every dollar of Medicaid spending, the federal government in Vermont pays about 60 cents.
Mm-hmm.
Now, part of the stimulus program, by the way, will increase that 60 cents to about 70 cents for 2 years. So, each state gets a portion of their Medicaid spending funded by the federal government, and that portion is determined by the income level, the median family income level in the state. And Vermont is about 60% federal, 40% state. It never goes lower than 50% federal, but for the wealthier states, the federal government funds 50% of the time. So that, in a sense, adds to the challenge of cutting Medicaid spending, because for every dollar we cut, we're only saving 40 cents, or for the next 2 years, 30 cents.
Yeah.
So you have to cut actually 3 times the amount of Medicaid spending
It's like the
to
inverse
achieve
of
that.
education spending.
Exactly right. That makes it even more challenging. But, I think, to answer your question, I think if we were to fully fund medical spending, healthcare spending in this country, or in this state, we would need to fund it with more money, and we could get that from the private sector, and we could get that through taxes. There's no question we could do that. The question is, do we want to do that? Is there enough demand within the state and within the polity, within voters, really?
What's the most, after a whopping 2 months on the job, what's the most effective way to provide the best coverage most efficiently to the most number of people? In 5 words or less, okay. No,
In 3 words, I don't know. And, I think I'm not dodging the question. I think I don't know the answer to that, and I don't think there's, let me put it this way, I think there are very few people in the legislature and even in the population at large that really know the answer to that. There's been a big push towards single payer, both nationally and locally. There's a bill now that is circulating with Michael Obachowski's name on it, but with also a number of other sponsors on it, and it's been pushed by Deb Richter, who has been a big proponent of single payer. So that will get a full vetting in the legislature. That has been out there for a number of years. This is not the first year that has come up. But I think that will get a full vetting. And as always, the devil is in the details. For the single payer, who will be doing the paying? Will that be funded through a payroll tax? Will it be funded largely through the system we have now, with some state contribution via the income tax, with some private contribution? We don't really know that, and candidly, I have not read the full bill. I haven't read it through, so I'm really
As a guy who works in both the private sector and now the public sector, now you have your one foot in each side of this. What are your thoughts on that? I mean, I know that your insurance costs at Sugarbush must be going up the same as mine are at my work.
It
Right?
is.
They're difficult, and they never go down.
My private sector thought is, I think most companies would do anything to relieve the burden of health care on their balance sheet or in their income statement. And I think, for us, say at Sugarbush, it has been a burden. It's gone up significantly. And in fact, I will reveal to you one of the maybe the most difficult meeting I ever had at Sugarbush happened a couple of years ago. We moved from 80% funding company, 20% employee, down to 75%, because after 5 years of absorbing that cost, we had to do something. We don't have the pricing power that would enable us to offset that cost with higher pricing. That was very difficult, and I'm sure what happened at our company was repeated many times over in other companies. And so slowly but surely, the private sector is either lowering their cost by increasing the employee cost, so they're essentially offloading the cost to employees, or in some cases, they're just getting rid of health care completely. Sometimes they're doing it surreptitiously by hiring contractors. Other times, they're doing it simply by eliminating the program. So in that sense, getting back to your original question, in that sense, I think as a private sector employee, I would celebrate a solution that would make us one of the payers, but not the payer. And I think ultimately, we are going to have to somehow figure out a way to detach health care from employment. we're just going
That's
to have
fairly
to do
telling.
that.
I mean, that's
I think we're going to have
jumping
to do
right
that.
out of that camp and putting it back in the public sector.
I think we're going to have to do that. But, and here's the challenge, Vermont, and Catamounts a good example, Vermont is concentrated very strongly on bringing people under the umbrella. And actually, if you look at the ultimate example of that, Massachusetts, that now has
Right.
mandated health care, they too have concentrated on bringing people under the health care umbrella. What we really need to work on now, and there are some people, I think Vermont is a little over 7, call it 8% of the people who are still uninsured. We need to move that down even more. I would say cut it at a minimum in half. Ideally, you'd have everyone insured. Most theorists believe that you're always going to have a 2 or 3% people uninsured because some people are moving into the state,
Yeah.
some people moving out. So, full insurance might be somewhere around, 2-3% of the population. Massachusetts is pretty much there. But the big effort has to be on then controlling the cost of insurance. And Massachusetts, to their credit, have focused on bringing people into the healthcare system, but they've done very little work on cost containment. I think Vermont has done a much better job, at least looking at and starting to address cost containment while we bring people under the umbrella.
Have we done very
so in terms of moving it off of the employment and into the public sector, to do that, either there's going to have to be dramatic increases in taxes or increases in payments to healthcare providers, or we're going to have to figure out a way to reduce the cost of healthcare. And those decisions will really not be any easier than the decisions we face now in terms of what to cut, what to keep.
Yeah.
Because healthcare spending, and we see this on the national level too, the president is certainly well aware of this, there are a lot of players in the system. And as one guy said years ago, he said, $1 reduction in healthcare spending comes out of someone's pocket. Either a provider, a hospital, a physician, an insurance company, and all of those people have reasons why the dollar should come out of someone else's pocket. But we do know in this country, without question, we spend far more than, I think, virtually any other. I don't know if there's any other country in the world that spends as much as we do per capita. So we know we're spending too much, and we know that because our results are no better than other countries. And you can make all kinds of arguments about how they're better some places and not as good other places, but the reality is we do no better as a country than most other countries, yet we spend quite a bit more. I will point out in that regard, and this gets into the idea of cutting costs. For me, maybe the most fascinating lecture that I attended about 3 weeks ago was given by a gentleman named Elliot Fisher, who's a physician and an academic at Dartmouth, the medical school there. And he and his colleagues were directed a study nationally on Medicare spending. Medicare is a great program to study. It's fully federally administered, so there's no disparity in terms of state by state, in terms of the administration of the program. And it's a homogeneous population. They're generally older people, over 65. So you can study it regionally and see regional disparities. What they found is the region that spends the most on Medicare per capita and the region that spends the least on Medicare per capita, there was a difference by a factor of 10. So there were some regions of the country that were spending fully 10 times what other regions of the country were spending on Medicare. So the obvious question, why? And they found a number of reasons, but by far the single most important contributing factor to that disparity in spending was the amount of medical care provided, was the number of physicians and facilities in the area. So what I mean to say is those areas that had the most physicians, that had the largest per capita medical care, were spending the most. And those areas that had the least amount of physicians and medical care were spending the least. And then the next question is, was there a disparity in the outcomes? And the most damning evidence was no. There was no discernible difference between those areas that were spending the most and those areas that were spending the least.
So the conclusion is too much access to medical care leads to too much use of it? with
Well,
no
you know,
discernible difference in,
There was an old joke
Helpfulness?
about the most dangerous thing to the polity is an unemployed lawyer. The idea that he or she will find work. Well, I think what we discover is that where you have physicians, they'll find work too. They'll find procedures to do. They'll find recommendations to make. And I don't mean to point the finger at doctors who are doing needless work. What I do mean to say is that if we are looking for things, if we're looking for disease, if we're looking for problems, it's likely that we'll find them. And sometimes those problems will be significant, and other times those problems won't be problems at all. So if you're looking at the cost of medical care, we need to figure out what's important and what's not. We need to figure out procedures. To go back to colorectal screening, sometimes you find lumps or sometimes you find tumors that are insignificant.
yeah.
If you're not looking, you're not going to find them. If you are looking, you will find them. Sometimes they're significant, sometimes they're not. And there are many people, and I'd be guilty of this too, who seek medical attention when really we don't need to. The old take 2 aspirin and call me in the morning sometimes is the best
Adam, let's,
solution.
we're going to run out of time here. I want to ask you on a couple more things that are going on in the legislature.
Yeah.
The same-sex marriage bill,
Right.
and of course Act 60 and Act 68, and retooling how we fund education in the state. So,
Deal with the first, and the second. Same-sex marriage bill will likely, not definitely, but it's likely that will come out of committee and be presented to the legislature. If I were a betting man, I would say it will pass
where do you stand on
comfortably.
it?
I support it. I was asked, in fact, to be a sponsor of the bill. I told them I was not interested in sponsoring it because I know that we have, I think this valley may be a microcosm of the state. I think there are many people who are very opposed.
Mhm.
I think there are more people who support it. I support it. I don't have religion on my support, but I do support it. I think it's something that...
I remember talking to you about this at a candidates forum
Right.
in October, and you did say, I do remember saying, how could you look at it if it were one of your children? How could you?
And that's why I support it.
Right.
If one of my children came to me and told me that they were interested in marrying someone of the same sex, I would have just great difficulty telling them not to and telling them I don't support them. But I do think it's a very difficult issue for many people. So my level of support, I think, reflects the fact that I personally think it's something that should be allowed. But I don't want to get up on a soapbox and start pounding the table, so I will vote for it. And I think it will come up in front of the legislature. I know there is a bill. I don't know. I believe it's in judiciary. Don't quote me on that. But I think that will come, and I think the same bill with Senator Campbell will come out through the Senate. So I think that's probably, it's a good likelihood that it'll come out. And I believe that there's enough support in the legislature to pass that bill. Act 60 and 68, if I had $1 for every proposal that's been out there and every bill that's been proposed, we probably, if I gave them
We
to
could
the Ed
fund
Fund, we'd be
education.
able to fund education.
And healthcare.
There are a number of initiatives that have happened. One, I would have a hard time handicapping one or the other. The governor appointed a commission of legislators and administration appointees to study the issue. That's going to come out. It's probably the 10th study in as many years. Am I confident that they'll come out with good recommendations? Not really, and it's not because they're not smart people, and it's not because they want to do it. Just that there are so many sides to the issue that I don't know where that will lead. So I have to be honest there. I will tell you that the recommendations that have come out have been everywhere from getting rid of income sensitivity completely and just giving people a blanket exemption on the first $60,000 of their property, to combining supervisory unions to save money on the administration of education, which I think will get a full vetting, to moving teachers' contracts to the state level, to get away from the idea of competitive pricing of contracts. I think that also deserves attention.
I have to back up. If people received an exemption on the first 60,000 of their property tax values, we do away with the CLA. How would you adjust for what 60,000 equals and a home in Warren versus a home in Rochester. Aren't those, would there be some, would that $60,000 exemption fluctuate along with the CLA of a town?
Yeah, I assume it'd be
Oh,
post-CLA.
Okay, would be tied to the
Post-CLA.
CLA.
So I think that would be the only way to make it fair. But to be candid, I have not read through that exact proposal. But I did give it a, but I think it would have to be post-CLA, because otherwise how would it be fair?
How could it be fair, right? So one other question for you. What's it like balancing your duties at Sugar Bush and your State House duties?
It's been a challenge. It's been a real challenge. There are many, I'll tell you an interesting example. There are many legislators, I would say the majority of the legislators are not working full-time.
Mm-hmm.
They have other issues going on in their lives, everyone does. But the colleague who sits to my left on the Healthcare Committee, George Till, representative from Jericho, in fact, he filled Gay Symington's seat when she stepped down to run for governor. He's a OBGYN. So from Friday afternoon, he typically leaves sometime after lunch, and he has appointments through the afternoon, and he works weekends. Maybe he's very popular in his practice because he has the weekend shift.
Yeah.
I have a similar schedule. I'm working weekends at Sugar Bush, and I'm usually there on Mondays too. The legislature is in session Tuesdays to Fridays. But it's very challenging. You also want some personal time with your family.
Sure. And you need a powder day. At a minimum of one.
We have precious few of those, so when there are some. But that has been a challenge. But, on the other hand, it keeps you fresh. For example, I'll give you an interesting example. The school holidays for Southern New England are over, and we have reasonable visibility about the rest of our year. So we've been sitting through budget meetings at the resort about where our revenue is, where our expenses are, which are eerily similar to the budget meetings. But I think that's healthy in that I think many people, and virtually everyone in the legislature, has to deal with some component of the budget. They have jurisdiction over some agency, over some department. So I think it's healthy to go through that exercise in our business, because in our business we know that there's only X amount of money there.
Right.
And I'll be the first to admit state government doesn't operate like a business. But I think it's healthy to have that perspective. So anyway, that's been good.
Thank you for coming in today.
Thank you.
Lisa Loomis with Mad River Valley TV, and with me is State Representative Adam Greshin, an independent from Warren who represents the Valley towns. A legislative update, and we'll be back in a couple of weeks for another one. Thank you, Adam.
Thank you, Lisa.